Hello guys, today we will talk about infection in the surgery, and what you need to understand. Infection in the surgery is not just when we have a microorganism inside our body. Sometimes it's happened on side our body. Okay, let's start it. Infection is defined by microorganism in host tissue or the bloodstream and inflammatory response to their presence. What about inflammatory response? We can have a localized inflammatory response and systemic. If we talk about localized, it is more important to remember that we have rubor, color, dolor, tumor, and functional as 5 signs what always will tell us about infection in our body. What about systemic? It is systemic inflammatory response syndrome, or how all world call it, SIRS. How you see, there is two circle, infection and SIRS, big circle. Yeah. Inside this circle we see a sepsis, more deep severe sepsis, and more deep septic shock. What you need to understand? First of all, we have infection. And sometimes we will have serious answering of our organism to this infection. All of it coming to the sepsis, but not always we have a severe sepsis or septic shock. Sometimes the sepsis will be severe, yeah, and not more often we will have the septic shock. When we talk about the SIRS, we talk about trauma, aspiration, pancreatitis, and burn. Any two of the following criteria. First criteria of the SIRS, it is temperature less than 36 degrees or greater than 38 degrees. Heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, tachypnea, white blood cells less than 400 cells in the millimeter or greater than 1200 cells. Sepsis, SIRS plus evidence of local or systemic infection. What do we mean? Two of these criteria plus confirmed or suspected infection. Septic shock, it is the sepsis, yes, SIRS, confirmed or suspected infection, and we have signs of end organ damage, hypertension, and lactate more than 4. Yeah, and how you need remembering mortality of septic shock is up than 40%. Trauma, aspiration, pancreatitis, and burn could cause inflammation without infection. Color, dolor, rubor, and tumor, heat, pain, redness, and swelling. The 4 classical signs of inflammation originally recorded by the Roman encyclopedist Celsus in the 1st century AD. Systemic inflammatory response affects all the body systems, white blood cells less than 400 in immunocompromised patients. Surgery, trauma, non-trauma, local invasion can lead to bacterial insult. One present bacteria initiates the host defense process. Inflammatory mediators are released, complement and plasma proteins are released, polymorphonuclear leukocytes arrive, etc. Many established factors have a role in infections. These can be either surgical factors or patient-specific factors. Patient-specific factors can be further defined as either local or systemic. Surgical risk factors. First, type of procedure, we'll mention it later. Second, degree of contamination. Third, duration of operation. And fourth, urgency of operation. What we need to remember about urgency of operation. Urgent surgeries not like elective ones. Surgeons have time to scrub and be prepared. Spread of surgical infections. First, necrosis infection. Second, abscess. Third, phlegmones and superficial infections. Spread of infections via the lymphatic system. And 5, spread of infection via bloodstream. Phlegmones. Early phase of abscess. Complication of surgical infection, fistulas and sinus tract, suppressed wound healing, immunosuppression and superinfection, bacteremia, organ dysfunction, sepsis, and systemic inflammatory response syndrome. SIRS. Fistula, an abnormal connection between an organ, vessel, or intestine and other structure. Fistulas are usually the result of injury or surgery. It can also result from infection or inflammation. Yeah, there you see a vesico-vaginal fistula, vesica-vaginal bladder, yeah, urinary bladder, vagina. And there you see a recto-vaginal fistula, vagina, rectal. Clinical finds and diagnosis. Physical examination, warmth, erythema, induration, tenderness. Laboratory findings, general findings, leukocytosis, acidosis, and signs of disseminated intravascular coagulations. Cultures, imaging studies, source of infection. Normal leukocytes, high neutrophils. When we talk about appendicitis, blood cultures are done if the patient is febrile and sick, but not after antibiotics. It will be usuals. Necrotizing fasciitis appears bubbly on CT scan. Yeah, how you see the space between the tissue is big. Examination, inspection, e.g. wasting of temporalis muscle, wasting. Loss of temporalis muscle mass commonly seen in case of significant catabolism and or general nutritional deficiency. Yeah, all patients with big infections will lose a muscle. Blood test, albumin to know the chronic status of the patient. Pre-albumin to know the current status of the patient. If it's more than, when can we say this weight loss is significant? If it is more than 10 kilograms over the past 6 months. Remembering this one, I will ask it in the exam. Treatment, incision and drainage, mostly with skin or mass lesion. Abscess, excision, sebaceous cyst, foreign body, diabetic foot, antibiotics, nutritional support. Infections, two main types, community acquired and hospital acquired. Community acquired, skin soft tissue cellulitis, group A strep, Staphylococcus, carbuncles, furuncles, Staphylococcus aureus, and necrotizing mixed. Hidradenitis suppurativa, Staphylococcus aureus, lymphangitis, Staphylococcus aureus. Cellulitis, diffuse infection with severe inflammation of dermal and subcutaneous layer of the skin. We see the pain, warmth, and hyperesthesia. Treatment, more often it is antibiotics, and sometimes we need to do the bandage with the special solutions, and sometimes we need to use a immobilization. Common pathogens, skin flora, streptococcus and staphylococcus, but more always, how you remembering, it is a streptococcus A. Furuncles and carbuncles. Furuncles and carbuncles are cutaneous abscess that begin in skin glands and hair follicles. Remembering about skin glands and hair follicles. If the pilosebaceous apparatus becomes obstructed at the skin level, the development of a furuncle can be anticipated. A carbuncle is a deep-seated mass of fistulous tracts between infected hair follicles. Furuncles are the most common surgical infections, but carbuncles are rare. Furuncles infect one hair follicles. Yeah, you see the normal hair follicles and glands. There you see a pimple. There you see boil or furuncle with the abscess. Boil or furuncle with the abscess. And there you see a carbuncle. Two or more hair follicles with the inflammation. Carbuncles, fistulas, and sinuses between a group of hair follicles. Yeah, the same. I just repeat for your better remembering. The sebaceous glands, it is the glands what are near the hair follicles. Don't forget about this one. The sebaceous glands open into the hair follicles, and together these form the pilosebaceous apparatus. Hidradenitis, serous skin infection of the axilla or groin consisting of multiple abscesses of the apocrine sweat glands. The condition often becomes chronic. The cause is unknown but may involve a defect of terminal follicular. Yeah, there you see small hidradenitis. Not often we have this one. More often we have like a big abscess. Treatment. The classic therapy of furuncle is drainage, not antibiotics. Invasive caruncules must be treated by excision and antibiotics. Hidradenitis is usually treated by drainage of the individual abscess and followed by careful hygiene. Usually not improved by antibiotics, it needs excision. Lymphangitis or blister. Lymphangitis arising from cellulitis produce red, warm, tender streaks 3-4 mm wide, spreads from the infections along lymphatic vessels to the regional lymph nodes. Yeah, you see how it's going with the lymph vessel. Lymphangitis. Infection spreads by lymphatic channels. In examination, you feel it as cord-like. Breast abscess. Staphylococcal infection, usually postpartum. MRCA is uncommon. Breast abscess, usually postpartum in lactation. Treatment, major. Abscess incision and drainage. Some surgeons try antibiotic if the abscess is not major enough or there is no fluctuation when they do the examination. Fluctuation is when we pushing on the volume, and if our arm go down and up, it is a fluctuation. But if we pushing and we feel just a volume without any flexity, we will talk about the abscess. If there is evidence of cellulitis, skin change, give antibiotics, but if the patient didn't respond, think of MRCA. Abscess. Infections accumulation of purulent material, neutrophils, in a closed cavity. Diagnosis, fluctuation test, movable and compressible. Treatment, drainage. But of course, first of all, incision and drainage. And I won't tell you that first of all there we have a atheroma, and after it we will have the infection of this one. Perirectal abscess results from infection of the anal crypts. Can be extensive, can result in bacteremia. Treatment, incision and drainage. Yeah, and there you see many types of abscess. Please don't forget about this one, I will ask this one. Diabetic foot infection. There you see managing of diabetic foot infection, and there you see stages. Yeah, first stage, second, third, and fourth. If we talk about hand infections, we talk about paronychia and phelon. Paronychia, an inflammatory reaction involving the folds of the skin surrounding the fingernail. It is characterized by acute or chronic purulent, tender, and painful swellings of the tissues around the nail, caused by an abscess of the nail fold. The pathogenic yeast causing paronychia is most frequently Candida albicans. The causative bacteria are usually Staphylococcus, Pseudomonas aeruginosa, or Streptococcus. Treatment is incision and drainage, if not responding, antibiotic. Phelon, close-spaced infections of the fingertip pulp. Treatment is incision, and paronychia always can lead to phelon. What can lead to tenosynovitis? What is the tenosynovitis? Is the inflammation of the fluid-filled sheet that surrounds the tendon, typically leading to joint pain, swelling, and stiffness. Tenosynovitis can be either infectious or non-infectious. Common clinical manifestations of non-infectious tenosynovitis include De Quervain tendinopathy and stenosis tenosynovitis, more commonly known as trigger finger. Diffuse necrotizing infections. Particularly dangerous, difficult to diagnose, extremely toxic, spread rapidly, often leading to limb amputation. Pathogenic factors: anaerobic, wound bacterial endotoxins, bacterial synergy multiple, and thrombosis of nutrient bridging vessels as a result of necrotising infection. First is a clostridial, mostly skin and soft tissue. There we talk about the necrotising cellulitis and myositis. And the second type is a non-clostridial, mostly deep to the fascia. Necrotising fasciitis, deep infection, and streptococcal gangrene, most common. Clostridial infection delayed for fastidious anaerobes. A broad spectrum of disease is caused by Clostridia, and on gram stains they appear as relatively large gram-positive rod-shaped bacteria. Clinical findings: crepitant absence of cellulitis in patients is usually superficial to the deep fascia and may spread very quickly, producing discoloration. Delayed debridement of injured tissue after devascularizing injury is a common setting. Treatment of Clostridial infections: broad spectrum antibiotics still you see the response. Crepitant abscess in Clostridial infections is less than 40% or less. Gas gangrene. Clinical findings: severe pain suggests extension in the muscle compartments or myositis. The disease progresses rapidly with loss of blood supply to the infected tissue. Profound shock can appear earlier, rapidly, leading to organ dysfunction. Air bubbles often visible on plain radiograph. Crepitus may be present but not reliable to differentiate. Yes, there you see a gangrenous tissue and there you see a healthy tissue. But if you see the redness, yeah, it is a border of the between the gangrenous and healthy tissue, and if you do the amputation, we need to on the more health tissue. Patient present with severe pain. Think about myositis. Gas gangrene spread by blood. There is a quick loss of blood that, if it's not treated, the patient dies or ends by septic shock. Non-clostridial infection caused by multiple non-clostridial bacterial pathogens. Microaerophilic streptococci, staphylococci, aerobic gram-negative bacteria, and anaerobes, especially peptostreptococci and bacteroids. Clinical findings usually begins in a localized area, such as a puncture wound, leg ulcer, or surgical wound. Externally hemorrhagic bulla are usually the first sign of skin death. The skin is anesthetic and crepitus is occasionally present. The facial necrosis is usually wider than the skin appearance indicates. At operation, the findings of edematous dull gray and necrotic fascia and subcutaneous tissue confirm the diagnosis. Crepitant abscess in non-clostridial infections is more than 40%. Treatment in clostridial and non-clostridial infections is debridement and oxygenation to enhance blood supply. Streptococcal gangrene group A. Streptococcus is a bacterium frequently found in the skin and throat. Streptococcal gangrene is uncommon. The sudden onset of severe pain is the most common, presenting symptoms usually in an extremity associated with a wound. Fever and other signs. Excuse me. Yeah, Streptococcus gangrene group A is a bacterium frequently found in the skin and throat. Streptococcal gangrene is uncommon. The sudden onset of severe pain is the most common, presenting symptoms usually in an extremity associated with a wound. Fever and other signs of systemic infections are frequently present at the time of presentation. Shock and renal dysfunction are usually present within 24 hours. Usually wound infections appear 7 days after the surgery, except streptococcal gangrene group A and clostridial infections which appear 1 day after. Treatment: complete debridement and the press-tight facial compartment, amputation. Broad-spectrum antibiotic therapy, resuscitative therapy, treat diabetes mellitus aggressively, And hyperbaric oxygenation inhibits bacterial invasion but does not eliminate the focus of infection. Biliary tract usually results from obstruction, usually suspects Escherichia coli, Klebsiella, and Enterococci. Acute cholecystitis, gallbladder empyema. Yeah, it's when we have the infection of gallbladder. Ascending cholangitis, it's when we talk about bile tract, yeah, and bile ducts, and ascending, yeah, when the infection go up to the bile duct and to the gallbladder. Peritonitis causes appendicitis, acute cholecystitis. Diagnosis, history, and examination. Treatment treat the underlying cause. Viral hepatitis, HIV, and AIDS. Tetanus. It's more important to remember. Clostridium tetani infections lockjaw caused by exotoxin. Treatment, immunization. Yeah, there you see contaminated wound, Clostridium tetani bacteria, tetanus neurotoxin, severe hyperextension, and spasticity caused by neurotoxin Clostridium tetani. Always check tetanus vaccine if trauma happens. Yeah, we need always remembering about this question because everybody have the Clostridium tetani vaccine, and if somebody haven't got it, we need to do it. Fever after surgery, postoperative infections. First one, fever after surgery. The 5 doubles possible cause for postoperative fever: wind, atelectasis, water, urinary tract infection, walking, deep vein thrombosis, wonder drug, medication-induced, and wound, surgical site infection are the causes of postoperative fever include. There we talk about blood transfusion, preoperative misdiagnosis, pneumonia, and malignant hyperthermia, one of the important and most common causes. Very important to ask about it in the family history. Malignant hyperthermia is a severe reaction of certain drugs used for anesthesia. This severe reaction typically includes a dangerously high body temperature, rigid muscles or spasms, a rapid heart rate, and other symptoms. Without prompt treatment, the complication caused by malignant hyperthermia can be fatal. Surgical site infections, SSI, third most common hospital infection, always happen after incision, superficial in depth, and or about organ space, generalist, peritoneist, or local abscess. Surgical sites are considered infected when there are systemic and local signs of inflammation. Bacterial counts more than 10 CFU ml in milliliters, purulent versus non-purulent. The length of stay for the patient and economic effects of the hospital stay are important factors to consider in SSIS. Note that surgical wound infection is SSI. Examine signs of infection could be superficial or deep, which reach the organ. Superficial incision SSI infection occurs within 30 days after the operation and involves only skin or subcutaneous tissue of the incision. Deep incisional, more seriously, extends past the superficial layer. The infection occurs within 30 days post-operation only if no implant is left in place or within 1 year if implant is in place and the infection appears to be related to the operation, and the infection involves the deep soft tissue, which includes the fascia and muscle layers. Organ space SSI. The most extensive of these surgical infections involves the organs and the space surrounding the organs. These infections can occur within 30 days post-operative if no implant is left in place or within 1 year if an implant is in place and the infection appears to be related to the operation, and the infection involves any part of the anatomy other than the incision which was opened or manipulated during the operation. SSI risk factors, duration of operation factors, and patient characteristics. If we talk about operation factors, we talk about duration of surgical scrub, maintenance of body temperature, the use of skin antisepsis, preoperative shaving, duration of operation, antimicrobial prophylaxis, operation room ventilation, inadequate sterilization of instruments. Foreign materials at surgical site. Surgical drains, surgical technique. Poor surgical technique includes poor hemostasis, failure to obliterate dead space, and tissue trauma. If we talk about patient characteristics, there we talk about evidenced age, diabetes, nicotine use, steroid use, malnutrition, obesity, prolonged preoperative stay, preoperative NARS colonization with Staphylococcus aureus, significant association, perioperative transfusion, coexistent infections, and altered immune response. Preoperative glucose control. Patients with a blood sugar more than 30 mg per deciliter during or within 48 hours of surgery had more than 3 times the likelihood of a wound infection. Shaving the surgical site with a razor induces small skin lacerations. It's a preoperative shave. Potential sites for infection. Distribute hair follicles which are often closed with Staphylococcus aureus. Risk greatest when done the night before. Patient education. Be sure patient knows that they should not do you a favor and shave before they come to the hospital. Prophylactic antibiotics. Antibiotics given IV for the purpose of preventing infection when infection is not present, but the risk of postoperative infections is present. Decreases bacterial counts at surgical site, given within 30 minutes prior to starting surgery. Vancomycin 1–2 hours prior to surgery. Redose for longer surgery. Do not continue beyond 24 hours. Surgical site prevention. Use antibiotics appropriately. Maintain normal body temperature. Maintain normal blood glucose. Optimize oxygen tension. Avoid shaving site. Treatment. Incisional open surgical wound, antibiotics for cellulitis or sepsis. Deep organ space, surge control antibiotics for sepsis. That's all what I want to tell you in this lecture. Thank you for attention and see you on the practice or exam. Bye bye.